So today's topic for discussion is chest pain or chest pain. Next. Chest pain beyond MI. The moment you utter word chest pain, right from the patient, his relatives, the doctors and the whole hospital staff get scared. They are at their they are immediately in a alert. They are alerted whether this is myocardial infarction or not. Every chest pain is treated as if it is a myocardial infarction, or at least it scares the person for that there is some emergency. So all chest pains may not be myocardial infarctions, but there are many other chest pains which can be as dangerous as myocardial infarctions. So from this slide you can see, right from this chest pain can be because of acute coronary insufficiency like myocardial infarction, or acute coronary insufficiency, unstable angina, can be because of the lungs like spontaneous tension pneumothorax, extensive pneumonitis, lung abscess, or it can be because of pulmonary embolism, can be because of the stomach related problems like esophageal rupture, acute gastritis, can be because of the herpes zoster upcoming, can be because of the chicken pox, and maybe a psychosomatic disorder. So what kind chest pain it is very important to find out what are the important causes of chest pain in addition to cardiac or acute myocardial infarction. So the chest pain is the commonest, one of the common complaint to the emergency department. About 5% of all the patients who report to the emergency department, they complain of chest pain. Wide range of etiologies is there, as we have seen. First, we'll see what are the 6 important causes of chest pain apart from the myocardial infarction, which if not diagnosed or patient is sent home, patient can die. How do you distinguish between the different causes of chest pain? Some cases we'll see how to diagnose them, and some non-cardiac chest pains, how to diagnose them and what is the treatment like. So, is your patient, who is your papa? When a patient comes to you with a chest pain, you have to find out who is his papa. This is the mnemonic used for, the Johnny Johnny yes papa. Similarly, it is who is the papa of this chest pain. So the important aspect is, first PA means a pulmonary embolism, second is a acute coronary insufficiency. Third and fourth PPA is either pericarditis, acute coronary pericarditis, pulmonary embolism, pneumothorax, and aortic aneurysms. These are the 5 or 6 important cardiac and pulmonary conditions which are as dangerous as myocardial infarctions, which should not be neglected, which should not be overlooked when a patient of a chest pain comes to you. If patient is sent home without diagnosis with these diseases, patient can die at home. So these are the important things apart from the other regular causes of chest pain. So the acute coronary syndrome, pulmonary embolism, acute aortic dissection, esophageal rupture, pneumothorax and pericarditis. These are the 6 important chest pain which patient, if not diagnosed on time, can have a catastrophic outcome. So how to approach a patient of chest pain? Approaching a patient with chest pain, first a patient with chest pain of unknown origin, when he comes to you, carry out the initial cardiac evaluation in the form of history of the patient. What type of chest pain it is? It's a mid-sternal chest pain radiating to the left side, which is associated with the breathlessness, radiating to the neck region, radiating to the jaw. From that you will be able to make out whether it fits into the cardiac chest pain or it is otherwise. ECG is a basic investigation which can be done in the routine clinic. stress test and coronary angiography to rule out the acute coronary events. These are the important investigations to find out whether it's a cardiac or non-cardiac. Carry out chest X-ray to rule out pneumothorax or any aortic dissection. So the six important causes of chest pain which can be catastrophic, you have to rule out either by proper history taking, ECG, further cardiac interventions if required, chest X-ray. So this will give us the diagnosis in most of the cases. So if the ECG, chest X-ray are inconclusive or are not able to give you a diagnosis, they do further analysis to completely rule out possibilities of acute coronary syndrome, pneumothorax or aortic dissection. So the chart will be something like this, although it is little smaller. If the patient has a ECG is normal, X-ray is normal, and there is no chance patient is unlikely to be cardiac, then you do a follow-up study. You check for whether the patient fits into his symptoms are suggestive of acute coronary syndrome or not. If they has a changes and the cardiac enzymes are positive, then treat him like a acute coronary syndrome. If his symptoms are not suggestive of, but the enzymes are still high, then you can treat him like unstable angina. If the patient's symptoms are not in favor of acute coronary syndrome and in cardiac enzymes and other interventions, they are also not favorable, then patient is likely to have a non-cardiac chest pain. The non-cardiac chest pain can be of a different type. It can be either because of the pulmonary cause or esophageal cause. The esophageal, check for the area, associated risk for pulmonary embolism and associated risk for the aortic stenosis. These are the other two causes which are important. If there is a patient has a history of DVT, has a long-standing OC pills, and suggestive of some female patient, young age, bedridden patient, then the chances of pulmonary embolism or suggestive of that is there. Do you think of the pulmonary embolism and do either a D-dimer if it is not suggestive? If it is suggestive, yeah, you can directly go for the CTPA or VQ scan. If that gives you the diagnosis of pulmonary embolism, you treat it accordingly. If it is aortic stenosis, if you are thinking of aortic, do a chest X-ray. If it is not favorable, then you can go for, if it doesn't give any diagnosis and still you think that the patient's symptoms are suggestive of aortic dissection, there are changes, the difference in the pulse in the upper limb, lower limb, or with both the limbs, depending upon the site of the aortic dissection, then you can go for MRI or a CT scan of the chest. So this is the flow diagram for diagnosing the patients with acute chest pain. Important chest pain which are non-cardiac, non-coronary, but can be catastrophic. If the history, ECG, test and coronary angiography all come out to be normal, evaluate for non-cardiac chest pain. Like this is another slide where if the patient you are suspecting that this may be esophageal, psychosomatic, or it can be local musculoskeletal. If it is a esophageal, then you can go for either OGD scopy and to find out whether it is a erosive gastritis or not. If the OGD scopy is normal, then you can go to do his pH studies of the patient. If it is a non-erosive gastritis, it can be treated with the proper appropriate treatment. If even the gastritis is not there, you can do the manometry of the esophagus to find out there is a dyskinesia or dysfunction in the esophageal sphincter or gastric sphincter to find out achalasia. Then you can go for the manometry also. So these all will give you the diagnosis about the esophageal diagnosis. Even the esophageal rupture can be diagnosed if it is there. If it is a musculoskeletal, you ask the patient to point out where exactly the pain is there. So that will give us the clue, which is induced by the movement. That will give us a clue about the muscular pain. Also, if it is a psychosomatic, they take the history of the patient, whether it is a recurrent, is it related to some event. That will give you the diagnosis or the clue about the possible cause of the chest pain. The general practitioner, important consider for general practitioner is that the patients who come to the general practitioners or to the regular OPD, most of them are likely to be a non-cardiac chest pain. almost 60% are the psychosomatic or GI related or gastritis or something like that. But the patients who come to the emergency department of a hospital, they are more likely to be related to those cardiac causes or catastrophic or little bigger disease compared to the patient reporting to the general practitioners. The common etiologies in the formal situation are gastroenterological, musculoskeletal, respiratory and psychosomatic in a general practitioner's clinic. The Marburg heart score is a useful aid to differential diagnosis of in the general practitioner's area. The general practitioners, most important consideration for general practitioner, this is called as a Marburg heart score criteria. 1 point for each is given, and you ask find out the patient's age and sex. When men aged more than 55 over or women aged 65 and more will get 1 point. If the known vascular disease of the person is having some known vascular disease like hypertension, then you'll get 1 more point. If there are symptoms are induced by exercise, then again he'll get 1 more point. The pain cannot be induced by palpation, then you'll get 1 more point. The patient suspects that the heart disease is the cause of his pain. Patients sometimes cannot describe, but he feels that my heart is paining, I'm having heart problem. So you give 1 point. And you calculate the total number of points. If it is 0 to 1, it's less likely that it is having a cardiac problem. If it is 2, then 5% chances are there that it is a cardiac problem. If it is a 3, it is a 25% chances. But if it is 4 or 5, 4 out of 5 are there, that means 65% of the chances that it is a cardiac in origin. So it is a simple test to find out whether it's a cardiac or non-cardiac in patients in a general practice. So if you go in, this is a big chart. This gives you the approximate idea about what kind of pain is there in different type of diseases. Distinguishing the various life-threatening causes of chest pain based on their presentation and diagnosis. So important life-threatening causes for chest pain, as we have seen. First is the myocardial infarction. In myocardial infarction, what is the kind of pain? The pain is a substernal type of pain, and it is excruciating substernal. This develops over a period of time. There will be associated pressure symptoms, there will be palpitations, the heaviness in the chest, and it builds over a period of some minutes to some hours. It cannot come suddenly also. It builds over a period of time, few minutes to few hours. Patient is unstable, patient has associated symptoms like sweating, dysphoria, uneasiness, breathlessness, he's restless, lightheadedness. So these are all symptoms of the acute myocardial infarctions. If it is a pericarditis, if it is a pneumothorax, the pain is typically on one side. It comes in a sudden way. It's a very sudden pain. It's a sharp pleuritic pain. It increases when patient breathes or tries to cough. So this is a type of pain. The patient is associated more of dyspnea, so unable to complete the sentence. If it is a pericarditis pain, the pain is a constructive type of pain, or it's a retrosternal pain. It increases on the movement of the patients, and patient can feel that there is something itching or something is going on below his sternum. If it is a pulmonary embolism, the pain comes as a sudden pain. It is a tight pain, substernal type of pain, substernal tightness in the chest. The patient may give a history of something like a deep vein thrombosis, like a pain in the calf muscles or sedentary work or some rest for long period of time. And if it is a dissecting aorta or aortic dissection, the pain is a lancinating or is a tearing type of pain. He gets a sudden, like of lightning, he gets a pain in his back, thorax, in the spinal region. So depending upon the presentation at the time of chest pain, can give you a little clue about what can be the presenting or what can be the diagnosis for this patient. So this presentation of the person is very important at the time. So the points to remember are always have the patient point to the pain. I always ask patient to tell where exactly it is paining, what type of pain it is, when it started, when it's getting, what increases, what relieves the pain. Do not only focus towards the acute coronary syndrome, as there are other causes of chest pain as we have seen. Stable angina pectoris is responsible for 10% of the chest pain in patients. presenting the chest pain in primary healthcare physicians, unstable angina or MI occurred only in the 1.5% patient. So chest pain patient also is more likely to be a stable angina rather than an acute coronary insufficiency. Approximately 60% of the chest pain diagnoses are not or non-organic in origin, not the cardiac, gastrointestinal or pulmonary. You do not get the proper diagnosis only for this. These are the non-cardiac pain or functional type of chest pain. So investigations for clenching the diagnosis of first important whenever chest pain comes, we have to rule out the acute coronary infarction, acute coronary insufficiency. The important investigation for that are you can do a CK and CKMBs. These are the important accepted as the best biochemical marker. They increase by, but however they lack the cardiac specificity, especially false positive can be there because of some other problem also. CPKMB is little more specific. It rise occurs 4 to 6 hours after the onset of the pain and stays for about 24 hours after the injury. The levels peak at 24 hours and returns to baseline after 48 to 72 hours. One advantage of CPKMBs over the other marker is that it remains elevated for a longer period of time and it is easier to detect compared to the others. Recently, in addition to CPK and CPKMB, you have a troponin test, that is cardiac troponin I and troponin T. They are little more specific for the cardiac injuries, which can be done on OPD basis also. Whenever a patient of chest pain comes here, you are not suspecting very extreme emergency, a patient is not very unstable, you can ask the patient to go for a tropi. Even the cards are available, which can be done in the OPD basis also, or in the casualty of any of the hospital. So the elevation of cardiac troponin I and troponin I can also be used to determine which patient are more likely to benefit from the certain adjunct therapies like GP2B inhibitors and all. So of all the three, cardiac troponin, myoglobin and CPKMB, troponin I is little more specific, it is more reliable, it can be detected in a more number of patients and can be positive for almost 7 to 8 days after the myocardial injury. So that is more specific compared to the CPK and CPKMB and myoglobin. There are some emerging new novel biomarkers for the diagnosis of cardiac event or cardiac injury. This is the BNP, that is a B-type natriuretic peptide, and the N-terminal pro-BNP. So these are the tests which are normally done in the ICU for the prognostication of the myocardial injury or the cardiac status. BNP has a prognostic value across the full spectrum of the cardiac diseases. BNP predicts high risk features in ACS. The high level of BNP is more predictable or indicates that there is a more amount of myocardial injury or more amount of myocardial ischemia is there. It's high values, if the BNP value is high, it indicates severe hemodynamic insult and due to the ischemia and the prognosis is worse. For convenient clinical use, you can quantify the BNP values and depending upon the amount or the quantity, you can say which patient is going to be benefited by revascularization or not, or what kind of prognosis the patient is likely to have. Another important thing which we do is a high sensitivity C-reactive protein, HSCRP. That is also indicator of the cardiac injury. There are low risk, average risk and high risk and very high risk. If it is less than 1, it is a low risk patient. If it is average, it is around 1 to 3. High risk is more than 3, and if it is more than 10, it is a high risk individual for cardiac events. There are some emerging biomarkers for the cardiac injury like myeloperoxidase, MPO, soluble CD40 ligand. These are all experimental, not normally done in our OPD or in our clinical practice. Ischemic pneumonia modified albumin can be done. These are all helpful in the prognostication of the disease of the cardiac injuries. Another important thing after doing the ECG and ruling out the cardiac events or the cardiac causes, important is doing the chest X-ray. How the chest X-ray of the pleural effusion will look, everybody knows. This is the type of pleural effusion. It's a bilateral type of pleural effusion, more on the right side. So pleural effusion is one of the important cause of chest pain. But chest X-ray is almost diagnostic of the effusion. Then you can get a pericardial effusion, where the widening of the CP angle between the diaphragm and the right heart border is narrowed. You can see the cardiomegaly also. This is indicative of pericardial effusion. This is a typical X-ray of pneumothorax, where the lung has collapsed, the diaphragms are depressed, there is increased intercostal spaces, so indicative of a tension pneumothorax. This is another tension pneumothorax where the lung is pushed towards the mediastinum and there is a visceral pleural and the parietal pleural thickening. The diaphragm is also slightly pushed down. See another CT scan which is showing the thrombus in the main pulmonary artery. So pulmonary embolism is one of the important cause of acute chest pain. Here you can see the collection of the blood in the pericardium. You can see the gray area which is a collection of the blood in the pericardium, pericardial effusion or a hemopericardium. Sometimes we do the calcium score of the coronary arteries to find out how much is the atherosclerosis. It gives us the idea about the atherosclerosis prevalent in the body. And depending upon the calcium score, if it is a 0 or none, there is a very low risk of atherosclerosis. If it is 1 to 10, it is a minimum. 11 to 100 is a mild score. 101 to 400 is a moderate, and over 400 calcium score is a very high risk for a coronary artery disease or atherosclerosis. Similarly, it can be mapped on the coronary arteries. We'll see one case also. We have a patient here, is a 60-year-old male with history of diabetes mellitus and hypertension, presents to the emergency department with a one-day history of retrosternal chest pain. So 60-year-old male with retrosternal chest pain. A chest pain began while he had been resting and continued to worsen over the next few hours. He described it as a sharp pain that is moderate in intensity and radiation to the right shoulder and neck. The pain worsens when he is lying down and with his deep breathing, but it is relieved by bending forward. He denies having any shortness of breath or palpitations. So this is a typical pain which is more on the right side, retrosternal, which is relieved by bending forward, but it increases when he is exerting and is radiating to the right shoulder also. On physical examination, the pulse is regular, blood pressure is normal. Neck examination shows no jugular vein distension, normal heart sounds, no edema or erythema in the legs to indicate pulmonary embolism or DVT. Homan sign is negative. Peripheral pulse is strong and symmetrical. The laboratory test, there is a normal CBC, slightly elevated creatine kinase. Initial management was done with the aspirin, oxygen, sublingual nitroglycerin and morphine because of the chest pain. Serial cardiac enzymes are negative. And this is the ECG. Here if you see the ECG showing the diffuse ST elevation. Very good. So the diffuse STT changes in all the leads is one of the indications. Is not always myocardial infarction, but it is more likely to be as he has rightly told, so pericarditis. So what is the probable diagnosis? Acute pericarditis, acute inferior wall ST segment MI, aortic dissection and pulmonary. These are 4 choices as I already told. It's acute pericarditis. And what are the ECG features of pericarditis? In a 12-lead ECG, patient with acute pericarditis classically shows the widespread concave upward ST segment elevation associated with the PR segment depression. PR segment is also depressed along with the ST, and there is no reciprocal ST depression in the other leads. The stage 1, there is a diffuse ST segment elevation and PR segment depression. In stage 2, there is a normalization of the ST and PR segment with flattening of the T waves. Stage 3, there is a widespread T wave invergence, and stage 4, normalization of the T waves. So depending upon the severity and the natural history of the pericarditis, you see that ECG changes also. So all ST elevation are not myocardial infarction. It can even be a pericardial effusion or pericarditis. So to diagnose it with the help of typical chest pain, pericardial friction rub, if you auscultate of the cardiac area, suggest ECG changes, typically widespread changes. So this is another important diagnostic criteria for acute pericarditis. Management is beyond our scope. So you can treat with if it is a painkillers or the NSAID is the mainstay of treatment along with antibiotics. This is another case. 42-year-old man presents with the hospital with a dull anterior precordial and stereosternal chest pain, which began acutely with the tearing sensation and has lasted for 3 days. He states that during the period he had been unable to get comfortable. The intensity of the pain increases during the inspiration and with body movements. The patient denies any symptoms of recent viral infection and has received no recent vaccinations. So this is a lancinating or tearing type of pain which is coming from last 3 days. In the history, no history of hypertension, CAD, prior cardiac injury, disability, diabetes mellitus or hyperlipidemia. He has no family history of the cardiovascular disease. Patient is taking no prescribed medication, over-the-counter medication or any other medicine. He denies illicit drug abuse. Physical examination shows alert but is comfortable. BP is high, that is 160 by 102. Pulse is 103. Cardiac examinations reveals early diastolic murmur in aortic region, no gallop, pericardial rub or shock. Abdominal findings are normal, cranial nerves intact and no neurological dysfunctions. So these are the findings on the clinical examinations. This is again a ECG. Exactly. Here also you can see the diffuse ST segment elevation in all the leads with the tachycardia. So this is another patient with ECG changes suggestive of acute coronary insufficiency, but can be something, diagnosis can be something different. If you do the X-ray of this patient, what does it show? It's an aortic aneurysm of the ascending aortic aneurysm, which is on the right side. Descending aorta looks normal, so it's either ascending and the arch of the aorta is, there is a dissection. The aortic dissection can be of a different level. 3 types of aortic dissections are there. What is the probable diagnosis at this point? He has already told us. Here also you see there's a diffuse abnormalities are there. The important thing to diagnose aortic dissection is always a CT scan or a MRI. Cardiac imaging or the CT will give you the diagnosis about the exactly filling defect you can see. Or in the 2D echo also or the transesophageal echo you can see the dissection of the aorta. You can see the false passage also. Aortic dissection can be of a different type and different level. Either it's a type 1, type 2 or type 3. Type 1 is only in the ascending aorta, type 2 is in the arch. Type 1 is starts from the ascending aorta and can reach up to the descending aorta. Type 2 is only in the arch. Type 3 is in the descending aorta after the origin of the left subclavian artery. And depending upon the suture, exact location and the severity of the dissection, the treatment can be either surgical or a medical management. It is a very small dissection, can be managed with the help of a beta blockers to reduce the blood pressure, reduce the heart rate. So patient can be little stabilized and the further dissection can be prevented. But the best option is go for a surgery. What are these non-cardiac chest pains? These are the chest pain resembles heart pain in patients who have no heart disorders. So this non-cardiac chest pain can be manifestation of other underlying conditions with different origins like musculoskeletal, pulmonary and gastrointestinal. Other terms used for this type of pain are just different doctors use different terms like atypical chest pain of undetermined origin, functional chest pain with normal coronary angiogram, unexplained chest pain, Doctor syndrome, Da Costa syndrome. So depending upon the origin of if it is non-cardiac, then you are little relieved, and only you have to find out to be sure that this is not some catastrophic event going on inside the body. I remember a patient about few years back getting admitted to a tertiary hospital in Pune with acute chest pain, acute left-sided chest pain. He came to the casualty. The moment he reached the casualty, he was immediately taken to the CCU. Patient was seen in the CCU, and immediately it was decided that he requires excruciating left-sided chest pain is there, but the ECG is normal, so he is about to infarct. So let's take him to the cath lab. Patient was willing, relatives were willing. Patient was taken to the cath lab. Angiography was done. Angiography showed triple vessel disease. Patient was immediately counseled. Patients were ready. Immediately, same day evening, patient was taken for CABG, and the CABG was performed. During this phase, a pre-op package was also done, and after the CABG, patient was much better, came out of the anesthesia, was shifted to the room again, was extubated, was with both the ICDs, was shifted to the room, and after the third or fourth day, when the drain was minimum, both the drains were removed. Drains were removed in the morning, and by evening he again started getting breathlessness, and he said, I'm getting the same pain what I was getting when I got admitted. Left-sided same pain what he was getting when he got admitted, he started getting the same pain. Then immediately multiple ECGs were done, echoes were done, but they could not find anything. The X-ray was done, and the X-ray showed a huge tension pneumothorax on the left side. Then they realized it is a pneumothorax and not cardiac event. So immediately the chest physician was involved. He was advised to put ICD. The ICD was put, and patient immediately became alright. So as a chest physician, he just went through the history of the patient. He saw whether the X-ray was done when the patient had come as a pre-op. The X-ray was searched. Fortunately, they got the X-ray also. It was below the last in the report. The first X-ray when he had come to the hospital, that X-ray also showed a tension pneumothorax. So actually the patient had come for tension pneumothorax. He was taken to the cath lab. CABG was done for triple vessel disease. Actually it was a pneumothorax, and when CABG was done, both the ICDs were put. So his tension pneumothorax got solved and he was feeling better. And when the tension pneumothorax, when his drains were removed, again there was a collection of the air and there was a pneumothorax. So ultimately the CT scan, HRCT of the scan of the thorax was done. That showed a ruptured bulla. So again patient had to undergo thoracoscopy with the thoracoscopic talc fluorodesis, and the patient was discharged with CABG and talc fluorodesis. So this can happen when we are unidirectional, or when the patient goes directly to a super specialist or directly to a corporate hospital, where the chances of unidirectional approach is little more compared to the patient when he comes to a general physician who has a holistic approach. He will think about everything, he will see all the reports at least. So another important cause for chest pain in our day-to-day practice is the costochondritis. The joints involved mainly are the multiple unilateral second to fifth intercostochondral junctions are the most commonly involved. Pain increases on the movement, pain increases when the patient is breathing. So when is any pain which can be induced by pressing is more likely to be costochondritis or musculoskeletal pain. These are the areas where you get the maximum pain. in the costochondritis or the Tritt's disease. So management, everybody knows. The underlying non-cardiac chest pain can also be esophageal origin, as we have seen them in the beginning. You have to go for endoscopy to find out the exact cause of that, either esophageal cause or gastric cause. If it is, you can do ambulatory pH monitoring of the patient for a specific and sensitivities can be done. Combined impedance pH testing can be done. Esophageal manometry and acid suppression therapy is the mainstay of treatment for these type of pains. Chest pain can also be because of the acute pulmonary embolism. Location of the pain is substernal. Quality of pain is pleuritic. Sign and symptom dyspnea, tachypnea, tachycardia, rales. Patient may be present with a hemoptysis. Any patient with a retrosternal pain or substernal chest pain, acute onset with hemoptysis, you should always think of a pulmonary embolism or pulmonary infarction. Diagnosing the condition is APG, there is a very severe hypoxia. ECG, you can see a typical S1, Q3, T3 may not be seen in all patients, but sudden change of axis if he has got his old ECG. You can do a VQ scan or a CTP or the CT pulmonary angiography. ECG is characterizing pulmonary embolism. Either you can see a tachycardia, deep S wave in lead 1, deep Q wave in lead 3, inverted T wave in lead 3. This is the S1, Q3, T3 triad, which can be seen in this ECG also, along with the tachycardia. So typical of acute pulmonary embolism when patient doesn't have a typical chest pain, but it is a pain which is explosion with more of hypoxia. And patient gives history of sedentary type of work, is lying for long period of time. There's a pain in the calf, then you should always suspect for pulmonary embolism. Echocardiogram will reveal the grossly dilated RV, severely hypokinetic RA free wall, RV apex contracts well, and PASP or the pulmonary hypertension can be seen as a patient may be having an acute cor pulmonale. Echo will be diagnostic. The chest pain can also be because of the pulmonary hypertension that we have to remember, and which is as catastrophic as acute myocardial infarctions. This is another case of costochondritis. So the key take-home message from all this discussion, or when a patient of chest pain comes, chest pain is the most common problem presenting in an acute setting and is caused by both cardiac as well as a non-cardiac chest pain. Chest pain is one of the commonest reasons for referral from a general practitioner to a physician or to a cardiologist or something. General practitioner, they can take chances with everything. Fever, pain in abdomen, headache, everything they'll take chances, but they normally don't take chances with cardiac chest pain. And that is one of the important reasons for referral to the other doctors or to the institute. The life-threatening causes, as we have seen, these are the 6 important life-threatening causes, which if not diagnosed or not suspected, patient if goes home without diagnosis can die. A stepwise differential diagnosis should be carried out, whether it is an acute coronary event or non-cardiac event, whether it is esophageal, whether it is a pulmonary, whether it is psychosomatic, it is a musculoskeletal, whether it is herpes zoster coming up or something like that. You should keep a checklist of what kind of chest pain it is. History and physical examination remain the front line of evaluations. That is very important, how the patient presents to you. General practice should be helped to make decision about referral patient as well as the managing those referred back from the cardiologist. Many times you refer a patient to the cardiologist, he says non-cardiac chest pain and sends you back without writing any treatment. So you have to take care of this other non-cardiac chest pain. Invasive investigation should be reduced by cardiologists by appropriate use of the risk analysis and non-invasive techniques. Thank you.